With any antiviral treatment regimen, drug resistance is always a concern. We saw with triple therapy with telaprevir and boceprevir that most failures of antiviral therapy were due to resistance of the hepatitis C to the protease inhibitor. With newer direct-acting antivirals, or DAAs, we expect that antiviral resistance will be less of a concern as we get more potent agents, and in particular, combinations of potent agents. We can expect that as a clinical concern, antiviral resistance will reduce. However, it still will be true that many failures of antiviral therapy will be due to resistance. And so it is important, as we start to use new cocktails of these antiviral drugs, that we make sure the choice of medications is correct, that patients are compliant with their medication regimen, and that we monitor the patients virologically in an appropriate manner. If we do not, we may see in clinical practice that the rates of resistance and failure are higher than in the clinical trials. This is particularly true as we start to treat more difficult to treat patients that may not be included in the clinical trials, like those with advanced disease, following liver transplantation, or other immunosuppression, or those that are HIV co-infected. Thus, it is important that we get good data on as many combinations as possible, and then choose combinations where the data supports a low rate of resistance. On the plus side, it seems that hepatitis C antiviral resistance is less of a problem than for HIV. This may be due to the fact that there is no DNA intermediate and that we can have curative therapies rather than lifelong suppression, and that those antiviral variants may decline with time, allowing retreatment, both with other drug classes as well as the same drug class in different combinations. So though antiviral resistance is always a clinical concern, it is expected that with the newer agents, antiviral resistance will be able to be prevented or overcome in most patients.